Welcome to my talk. Paul and any of the other organizers, thank you for the invitation to participate in this most bizarre version of a low-carb conference, low-carb Sydney. It being bizarre, of course, has nothing to do with the fact that it's Australian. I'm thrilled to be involved. And I'm glad to be able to share some of this message of, if you will, my way of looking at things, my paradigm, which is placing insulin at the center of health and certainly disease in multiple contexts, and most particularly the metabolic syndrome. So with that in mind, I'll just get started. My disclosures here, I've written a book, so I will receive royalties from the sale of that book if it sells enough. And I'm the co-founder of a supplement and education company, Health Code. I'm also a scientific advisor to a United Health Group, which is an insurer, and to Unicity, which is, again, an international supplement company. Now, to get things started and to give this some context, like I'd mentioned earlier, diabetes is a particularly relevant problem globally. And within the United States, it is a problem, as shown here, with regards to the leading causes of death. In diabetes is placed, certainly within the top 10, coming in around number 7. But I submit that this is somewhat misleading because most people don't die with diabetes as the main cause. It's not that diabetes has killed them. It's typically that the diabetes is aggravating or exacerbating or even outright causing a different situation. And so I've indicated that here, really, I think, helping us appreciate the relevance of diabetes well beyond its narrow, small, the confines of diabetes itself. It touches on so many different disorders, heart disease, cancer being right at the top of the most lethal of these diseases. Now, if we step back a little bit, and rather than just look at what's killing people, look at how prevalent some of these problems can be, we get a better idea from the study published at the end of last year. This study determined that 88% of adults in the US, and again, pardon the American-centric paradigm here, but that's where I am, and so I'm going to present it that way. Needless to say, we would see similar results throughout the world. In some places, even more dramatic, like perhaps the Middle East, and in others, like Australia, it wouldn't be quite as bad, but all going in the same direction. And nevertheless, they conclude that 88% of adults are metabolically unfit, and they base this on someone meeting the criteria here of what is defined as what they're defining as metabolic health. So only 12% of adults in this survey were okay in all 5 of these areas. So a narrow enough waist circumference, a normal blood pressure, normal blood levels of HDL cholesterol, triglycerides, and glucose. So that's how they define metabolic health. And interestingly, it's this constellation of variables, a certain number of them, that constitute the metabolic syndrome. It's when these health markers are in the wrong direction, where someone would be considered metabolically unfit or meeting the criteria of the metabolic syndrome. Interestingly, the metabolic syndrome, of course, was once referred to as the insulin resistance syndrome when this was first presented. However, metabolic syndrome simply sounds better. But I think it's somewhat misleading. And if we had kept the title of this being insulin resistance syndrome, I submit that it would actually help us understand these disorders more. It is far more descriptive and accurate of a name rather than metabolic syndrome. So what is insulin resistance? If I'm putting it at the middle of that insulin resistance syndrome, let's define it. Let's get to know the villain here in this story. Now, insulin is a hormone that's flowing through all of our blood. It's made from the pancreas, unless we are a type 1 diabetic. Then we have insulin flowing through the blood all the time. Every cell in the body has insulin receptors, and I mean every cell, bones, muscles, from the bottom of our feet to the hair on the top of your head, we've got insulin receptors. Now, insulin will bind this receptor. It's essentially a door that only insulin can knock on. Insulin will come and knock on that door, and then just as if we were knocking on the door of someone's house, someone will come and answer the door, or something happens inside the home because of that knocking door. In my home, it would be that the little puppy starts barking and the kids start fighting over who can run to the door first. Whatever it may be, there's a response. So I'm just going to call this action. And I do this not to avoid being specific, but really whatever the action is depends very heavily on the cell. Insulin will do something differently at a liver cell as opposed to a kidney cell, as opposed to a neuron. So there are different effects. I'm just calling it action. So insulin comes and binds the insulin receptor, then there is a cellular action. Now, one prominent action in the body is that glucose that is outside the cell will be ushered into the cell. It will, if you will, it will walk in the door that insulin allows to be opened. So blood glucose levels will come down when insulin is elevated. Now, over time, this action can be diminished, and this is one of the two important points to make about insulin resistance. It's that insulin has a diminished action. Now, this is not universal throughout the body, but it happens in a few important cells. So as this diminished action occurs, we have then consequences. One being that glucose starts to climb because the body, and this is especially relevant at the muscle, so when the muscle becomes insulin resistant, its ability to pull in glucose in response to insulin is compromised. And then insulin itself begins to elevate. Now there is a part of a vicious cycle here, so it's difficult to, in fact, I would say it's difficult, I was going to say it's difficult to pinpoint one beginning, but I'll be more accurate. You can have multiple sites of origin, but that's a talk for another time, talking about the specifics with regards to the origins of insulin resistance. But here in this very simple description, we've come to this point where if this given amount of insulin was not enough to do the effect, like, for example, lower blood glucose, so the body makes more insulin. Now, what was once a polite tapping at the door has become a pounding, if you will, and this is sufficient to overcome that diminished action in response to a given amount of insulin, and the action essentially goes to some degree normal. So there are two important takeaways in defining insulin resistance. One is that some events or actions within the cell are compromised in response to insulin. And then second, and this is often overlooked, but it is an essential part of the definition of insulin resistance, and that is that blood insulin levels are actually elevated, so a hyperinsulinemia. Now, if we looked at this again in the context or through the paradigm of glucose, which is a bit unfair, and I'll come to that later, it would look like this. This is the normal situation, the healthy scenario, where glucose is normal and insulin is normal, but in insulin resistance, it is importantly that glucose is normal, but insulin is not. This is insulin resistance. And I will present this in a slightly different paradigm in just a minute. So essentially, more insulin is required to keep glucose at a normal level. So these are the 5 aspects of the metabolic syndrome, or as I submit more accurately, the insulin resistance syndrome. Let's just kind of go around them briefly and look at how each of these is relevant or derivative of insulin resistance. Now, glucose, this one's quite obvious. As someone is living a life that is constantly elevating their glucose, chronically elevated hyperglycemia is lethal. And so the body wonderfully has this mechanism to prevent that. Darn cell phone. So the body has a mechanism to prevent that chronically elevated hyperglycemia, and that is, of course, insulin. So constantly bumping up glucose in the diet will result in constantly bumping up insulin. As the insulin is chronically elevated, the body will become progressively resistant to that insulin. Now, I understand that there is some opposition to this idea, and that is unfortunate. There are multiple studies from humans and cells and rodents identifying that this is a real phenomenon. Chronically elevated insulin, not even that chronically elevated, will result in insulin resistance. Now, as this continues, we then start to feed this vicious cycle where the elevated glucose is driving elevated insulin, which is driving insulin resistance, which in turn is pushing up the glucose. So this is often one of the end results of chronic insulin resistance, is that the glucose finally starts to climb, and then we spill into the realm of type 2 diabetes. But again, I'm getting a little ahead of myself, and I'll come to that in a bit. Now, what about waist circumference? I appreciate again that this is something that is quite debated, and I get this debate, the effect of insulin on body fat. There are two phenomena that I'd like to refer to. One is how insulin will reduce metabolic rate, and of course, as metabolic rate goes down, the body will be more inclined to store energy. So this checks the box of the calorie in, calorie out model, but interestingly, we're doing that through the context of insulin. So it's also part of the endocrine model to describe obesity. And then second, it's the direct effect of insulin on fat cells, stimulating the fat cells to grow. So first of all, with metabolic rate, this is a remarkably old finding. In 1912, two of these legendary scientists, Elliot P. Joslin and Francis Benedict, each of them were just they are legends in their field. Joslin in the field of endocrinology and Benedict in the field of energy expenditure and metabolism at the level of the whole body. So in 1912, they published this report finding that in type 1 diabetes, untreated type 1 diabetes is associated with this significantly elevated metabolic rate. Now, there was some interesting follow-ups to this in the 1980s from Sri Nair, who's a modern sort of legend, if you will, in the realm of metabolism and mitochondrial research. I'll point out a few things here worth noting, and I've highlighted that in the green boxes. First of all, they used some formulas to predict what energy expenditure ought to be based on body mass, and that is actually partly derived from Dr. Francis Benedict's work. Nevertheless, based on the body size of these individuals, an untreated type 1 diabetes or poorly treated, so underdosing insulin, their metabolic rate should have been in the mid-1700s calories per day, but they found that they were actually about 300 calories higher, so sort of 15 to 20% higher than it should have been based on the body size. And now, interestingly, as we shift over to the right, when they began insulin therapy to properly control the diabetes, the metabolic rate slowed down by about 300 calories, putting them right within, remarkably accurate range of what the formula predicted they would be based on their body size. And this idea of body size being coupled to metabolic rate is one I'll come back to in a bit. But over on the left of this slide, you'll see that minute by minute, with the beginning of insulin therapy, they could detect this steady drop in metabolic rate. So this is a real phenomenon that happens in real time. Even in type 2 diabetes, with the beginning of insulin therapy, metabolic rate starts to slow. And I won't get into the details of my study, but you could look this up from a couple years ago. We found that insulin, part of this effect at the whole body level, may be that insulin is slowing the metabolic rate within the fat tissue itself, among other places undoubtedly. Actually, let me back up quickly and mention here, often people will invoke the glucose wasting, the glucoseuria, the glucose spilling into the urine, as an explanation for why type 1 diabetics are so underweight when they're poorly treating their diabetes. And that is very likely to some degree relevant, no doubt. If you're spilling glucose into your urine, you are losing calories. However, that wouldn't account for the increased metabolic rate. That would certainly go hand in hand with increased metabolic rate to explain why they are so thin. Anyway, I hope that makes sense. Now, to this other idea, or furthering this idea of insulin and body weight, when we aggressively use insulin to control glucose in type 2 diabetics, whether it's a conventional therapy or a more intensive, so more aggressively increasing the insulin even more, they will gain a significant amount of weight. Now, when we look at weight, and I mentioned this just a moment ago, another study in type 1 diabetics found that with the beginning of insulin therapy, they gain a significant amount of fat, no significant gain in lean body mass. Interestingly, despite this weight gain, the metabolic rate, which is over here on the right side, started to slow as the insulin therapy was increased. This is a unique phenomenon within human physiology. Typically, as I indicate here, as body weight is going up, so too does metabolic rate. Now, this is in adults that are grown. Of course, it's obvious if you're looking at an adolescent who's going through puberty and experiencing explosive growth, but that's not what we're talking about. We're talking about adults. If an adult gains weight, their metabolic rate goes up. If an adult is losing weight, the metabolic rate is going down. So typically, these two things go together. Now, interestingly, based on the data I've shown you, when insulin therapy is thrown into the mix, or just bumping insulin up higher than it was before, we separate these two. And now, so essentially, we uncouple body weight from energy expenditure. This is important, and again, I believe it's all part of the relevance of insulin resistance in an expanded waist circumference, which is the topic at hand. Now, with regards to the actual size of fat cells, if you take diabetics who are using insulin, exogenous insulin as part of their therapy, at the sites of insulin injection, we have significant increases in the size, roughly 3 times expansion of the diameter of the fat cell. And we see that here in panel B that I'm kind of circling with my cursor here. The big adipocytes compared to these much smaller and indeed more vascularized adipocytes in the even in the same person at the areas where they aren't injecting insulin. So just 2 different fat cells. And this is what it can look like when it's done in one spot, insulin therapy, insulin injections in one spot for a long time. Indeed, this insulin-induced adipocyte hypertrophy is one of the reasons why the reason why type 1 diabetics are told to rotate their injection site. It's because all that insulin in just a few fat cells makes those fat cells uniquely big, as opposed to expanding fat cells in size throughout the whole body. Now, let's move on then to blood pressure as we continue to circle around insulin resistance. This is all through the actions of a hormone called aldosterone. And when insulin goes up, aldosterone goes up. And aldosterone's main effect, among many actually, is to induce the salt and water retention or resorption at the kidneys. And then as volume goes up, of course, pressure will go up as well. And so we have an increase in blood pressure. Now, what about the bottom two, triglycerides and HDL cholesterol, 2 common lipid markers? Well, in fact, this slide has a big story to tell, but the story I want to focus on is just that low triglycerides and high HDL is looked at as an indication of insulin sensitivity. And in contrast, if someone has high triglycerides and low HDL, that is an indication of insulin resistance. And in fact, that's how they defined insulin resistance in this study, a high triglyceride to HDL ratio. And just for the sake of time, I won't talk about the mechanism, also partly because I'm not a lipidologist, but suffice it to say, hyperinsulinemia and insulin resistance will reduce HDL cholesterol levels in the plasma, and in contrast, they will increase LDL, which of course, looking at this paradigm, LDL is derivative of VLDL, so that would be the next step. Now, beyond the insulin resistance syndrome, insulin resistance has a hand in many diseases, including these big 3, diabetes, heart disease, and cancer, but also several others that you might not expect. I've already touched on body fat, but Alzheimer's disease, the most common form of dementia, stroke, arthritis, migraines, infertility in men and women, and fatty liver disease. Each of these diseases is either caused by or exacerbated by insulin resistance. So insulin resistance is extraordinarily relevant in these non-infectious chronic diseases that we're all worried about. Now, with regards to diabetes, and one of the central tenets of this talk, I think that if we appreciate the role of insulin resistance in type 2 diabetes, we look at type 2 diabetes with a far greater degree of accuracy. So in looking at insulin resistance, commonly the typical marker that we're searching for is looking at glucose. That's what we want to look at, and that's what we want to track. And over the life of a person progressing towards type 2 diabetes, the glucose levels are going to look something like this, starting normal and then becoming progressively elevated. Now, this is excusable, despite me disagreeing with it, and I will make the case that it is wrong. I think we can nevertheless be sympathetic to that perspective, and certainly sympathetic to people who hold it despite the evidence. Now, the evidence in favor of it is historic and scientific. Very briefly, because I'm not a history professor, the historic reason is excusable, partly because the most common manifestation of someone with diabetes, most specifically type 1, but even type 2, would be that they would be urinating a lot, the polyuria, due to the high levels of glucose. The kidneys can't resorb that glucose, and so the glucose will stay in the urine within the kidneys, and that will pull water with it. So the person's producing a high volume of urine, and it will be enriched with glucose. Now, second and more modern, it would be the scientific justification, and that is simply that it is easy to measure glucose. When you can oxidize the nutrient on a teeny little strip that has enzymes on it, it gives you a lot to play with. Much easier to measure, I should say, to be clearer, as opposed to trying to measure hormones on something like this. So measuring glucose is easy to do, and thus it became relevant because people could track it. We can all measure that on our own at home, let alone in a doctor's office. Now, with that sympathetic perspective in mind, let's transition to making the case that it's not excusable and nowadays, and that insulin ought to be the metric that we're scrutinizing when we want to understand type 2 diabetes. And if we superimpose insulin over the lifetime of someone progressing towards type 2 diabetes, it would look something like this. It starts low, it elevates significantly, and then it starts to come down, but it is nevertheless higher than it was before. That is so important because so commonly this part here, where insulin starts to drop and then glucose starts to climb, commonly in the literature we will say insulin is insufficient to keep glucose in control. And that leads some to erroneously conclude that insulin is essentially zero, and we use that as justification for insulin therapy, but it is not. While that is technically accurate language, it is misleading to say that insulin is insufficient. We should be clear that it's insufficient to keep glucose in check, but it is still elevated. Anyway, insulin has that progression. I want to note two specific timelines as if we were moving along that x-axis through time, through the life of the person. This first stage is the insulin resistance stage, and you'll note that it is defined by elevated insulin, but normal glucose. This is where most people fall nowadays, unfortunately, certainly in the US and other countries. And then as this progresses, in not everyone, but many of these people with with insulin resistance will progress towards type 2 diabetes, but not all of them. But this is now where insulin is still higher than normal, but it may start to drop, and now glucose levels will start to accelerate and climb. So insulin is elevated and glucose is elevated. But insulin is the key variable here. You can see how it starts to climb so much earlier than glucose does. And this is played out in the literature, this interesting report finding that in people with type 2 diabetes, if you're looking at insulin and not glucose, we can detect changes a decade, and I would submit more than 1 decade earlier than the glucose changes. And if we're looking at insulin resistance, then this study is making the case that it's insulin, not glucose, that should be used as the marker of the disease. Now, unfortunately, and I alluded to this a moment ago, when we focus on glucose, we do whatever we can to push the glucose down, including bringing insulin back up to where it might have been and even beyond, so to superphysiological levels of insulin. So we begin treating the patient with insulin therapy, and then that will most certainly push up the insulin, but conventional medicine would say, who cares? We don't care about the insulin, we care about the glucose, and because the glucose is going down, well, then we're doing what we want. The tragedy in this paradigm, and I won't take the time to show you the data, but one, we not only have a significant increase in body fat, the diabetic who begins insulin therapy can expect to gain up to 10 plus kilos easily of fat. The risk of heart disease will climb by multiples. The risk of cancer, mortality, actually dying from cancer will go up, one particular study, by about 90% with insulin therapy. So this has meaningful consequences. And while the one consequence might be a benefit, namely lowering glucose, it comes at a heavy price, where the diabetic can most certainly expect to gain weight and die sooner. And that should be the outcome that matters. So what is a takeaway then, as I'm wrapping this up? If we look at insulin levels, I make the cutoff of around 6 microunits per mil. This is based on evidence, and I have some studies linked here, where healthy people, based on people not adhering to a Western diet or a processed foods diet — I shouldn't call it Western, it is global — but a diet that is based on processed foods, they're going to have insulin levels around 4 microunits per mil. And these are people who have extremely low levels, if any, diabetes at all. Importantly, the average American has insulin levels of around 9 microunits per mil. And oddly, that fits within the healthy range of most clinical cutoffs for insulin. Unfortunately, there's no consensus on these numbers, but that would fall within a healthy range on most blood tests. And I think that is misleading, because the average American, of course, based on that study published last year, is metabolically unfit. Remember, 88% of these people with an average insulin of 9 microunits have aspects of the metabolic syndrome. So 6 microunits range that's in the middle of these two cutoffs is going to be one that people should shoot for, and thank heavens they can, based on dietary changes that I won't take the time to describe now, but most certainly other people will in this meeting. And indeed, the dietary strategy that I believe is best is encompassed in the very name of this low-carb Sydney meeting. Now, so in conclusion, these are the aspects of the insulin resistance syndrome, nowadays referred to as the metabolic syndrome. And guys, thank you for listening. I hope this has been instructive. Again, my main hope is that we can appreciate the role of insulin and insulin resistance, not only in diabetes, but also in virtually any disease related to cardiometabolic disorders. These are the labs at BYU that I'm associated with, and there are my social media handles. Thank you for listening again, and I hope you found it instructive.
A great talk from Ben Bikman. Everybody loves Ben Bikman, don't they?
Well, I think so. If we created a soft toy line of low-carb characters, I think Professor Bikman would be the bestseller.
Well, certainly better than Preston Company anyway. The concept of metabolic syndrome, more accurately being described as insulin resistance syndrome, is a good one, I think. And I sometimes wonder maybe we should go back to that original terminology.
Well, I think it would offer clarity, because the term metabolism to many people, both inside and outside the medical profession, doesn't really mean a heck of a lot. But when we talk about insulin resistance, we're starting to get more of a grasp on that. And certainly I think that extra description would empower people to take action.
And that scary stat about 88% of Americans being metabolically unhealthy. So in other words, having one of those signs of the metabolic syndrome is quite astonishing.
It's frankly scary. So only 12% actually passed on all 5 metrics of the metabolic syndrome. I mean, it really says a lot. We're in quite a damned state right now.
And I'm sure it's very similar in most Western countries and, well, most countries generally.
Well, Professor Bikman even alluded to some countries being worse, like the Middle East. And I mean, certainly we've heard Professor Lustig talk about their high fructose consumption and stuff like that, so we can probably understand it. But the scary thing is, it could be worse.
Very scary. And as we've seen recently with COVID-19, I mean, it is clear evidence that those metabolically unhealthy people do not do well in this situation.
Yeah, well, I mean, I counted 11 separate conditions that was just presented there that was made worse by insulin resistance. This is the central scourge of modern health. I mean, it comes down to insulin resistance. And even if we just have a look at what happens with weight loss, I mean, as was very well presented, very clearly presented then, there's a 1-2 punch. Have high levels of insulin because you ingest too many carbohydrates, and Ben was very explicit that this does happen despite people saying that carbs don't cause that, then that high level of insulin will stimulate fat storage at the same time as reducing your energy expenditure. So...
bad combination.
And I mean, as we know, he presented one study there that showed a difference of about 300 kilocalories a day compared to people with low and high insulin levels. And interestingly, that was the same as the study published in British Medical Journal by Ebeling and Ludwig. They found about 300 kilocalories a day difference. So there really can be no doubt that he's hit the nail right on the head.
Yeah, fascinating. And I think the real challenge I certainly find with patients and so on is trying to explain insulin resistance, and I thought he did a really good job of that.
Super crisp graphics. I mean, he's a brilliant presenter. I mean, his students are lucky to have him.
Yeah, great talk.